a tool to help address homelessness. And we are thrilled to have our speakers here today to help us present. I wanted to just check before I introduce our speakers, will one of you be pulling the PowerPoint up or would you like us to do that?
You can go ahead and run the PowerPoint. I wasn't planning to. Eileen, are you okay with that?
Good. Okay, great. We'll do that in just a second. So first, I want to say, I first want to acknowledge that Denise Likar is here from SCAN Health Plan, and actually from the part of SCAN that is called Independence at Home. And we go way back, and I'm thrilled to have her presenting today. She's a real expert in older adults, works a lot on policy issues, and is just a great resource. I also would like to introduce Eileen Koons from Huntington Senior Care Network. Eileen actually and I also have worked together for many years, and Eileen has done an amazing job with the Senior Care Network program at Huntington Hospital, and is also a great resource for all things older adults. We also have Aloyce. I'm looking and not seeing her here. So we are expecting.
I am here. Can you hear me?
Aloyce, there you are. I see your face.
Okay.
Aloyce and I are newly acquainted, but I'd just like to acknowledge that she's with Partners in Care Foundation, also another great organization serving older adults. So thank you for joining, Aloyce, and thank you for calling out. So, okay, with all that being said, I'm going to turn it over to our presenting team. I will take just a minute to pull the PowerPoint up and then we'll get started. And I will go off video for a minute while I do that.
Great. Well, thank you, Gretchen. Good morning, everybody. And so while Gretchen is pulling up the PowerPoint, we hope today to be able to bring you an overview of the Multipurpose Senior Service Program, MSSP. All three of us, Eileen, Aloyce, and myself, run sites here in Los Angeles County. The county is actually broken up by zip codes. And between the three of us and two other agencies, Jewish Family Services of Los Angeles, as well as Human Services Association out of Bell Gardens, between all of us, we cover Los Angeles County for this wonderful program. And so since introductions were already done, why don't we go ahead and just advance into the first slide. So today our goal is to bring you through the components of MSSP to give you an overview of the program and to really walk you through how MSSP really is a safety net for older adults. We've been around for a long time, and we actually have probably some value to the teams that are here today in order to really look at, once somebody an older adult is rehoused, how can we continue to support their long-term stabilization in the community. Next slide. So MSSP started as a demonstration in 1977, so been around for a bit. The premise of the demonstration in the 70s was we need a program that older adults with Medi-Cal have options other than nursing home placement. And that is the premise of which, and looking at it's actually more cost effective to keep people at home than in a nursing home. And so that's kind of where this all grew out of in the 70s. And we became the demonstration was successful in showing the ability for the program to really keep people in the community and give them choice. And we became a home and community-based services waiver in 1983. That's a federal waiver that helps fund this program. And with that waiver, the real focus of the waiver is to really support those nursing home certifiable seniors that are living at home at no cost, and that's cheaper than a nursing home placement. So what we really our clients are 65 and over. They're going to have Medi-Cal, and their Medi-Cal usually comes with no share of cost. There are situations where there may be a share of cost and we help with, But it really is that piece of stabilizing them, helping them avoid that placement in a nursing home. And it's a long-term program where we really are taking care of the frail, most vulnerable, and at high risk for poor health outcome individuals and help them maintain in the community. The program is voluntary, so the person can sign up or opt out at any time of the program. And it is a program that's been around for many years, and so our case management model has been validated as being evidence-based and a good component of care embedded into the system of care. Right now, MSSP serves 12,000 participants annually, roughly, statewide. There's about 3,400 of those in Los Angeles County. We will be gaining additional slots in January of 2022. In the recent budget, we were allotted another 2,700 more slots statewide. And so those will start to come online early next year, and it'll probably roll out over 2022. And then the last bullet I can't see on the screen is regarding what our staffing component looks like. And so MSSP has both social workers and nurses, and our RNs are responsible for doing the nursing home level of care certification, at least annually or with a change of condition. And these are based on the Title 22 regulations that a usual nursing home uses, but we're applying them in the community setting in order to keep them from nursing home placement. Next slide. Okay, Eileen.
Thank you, Denise. So as Denise sort of talked about the broad overview of MSSP and who qualifies for MSSP, you know, it's important to understand this is a care coordination program. And it's also important to define what do we mean by care coordination, because there's so many, that term is used quite a bit. And so when she talks about evidence-based, and when she talks about, you know, the long-term model of care, what we mean by that is starting out, once we determine that somebody qualifies and then we enroll them in the services, you know, obviously they're a voluntary participant, as she mentioned, then we conduct a standardized assessment. And it's actually two assessments, two components to it. One is a nurse, an RN that is, for the most part, public health nurses who are assessing all the health-related aspects, their health history, their health status and conditions. And the social worker is conducting the psychosocial assessment. And so those two together really provide a wider, you know, kind of a wide view of what's going on in the home, what's going on with the individual, what's going on in their setting, you know, where they live, and what sort of needs that they have. And that assessment is the basis for a care plan. And our care plan is risk-based. You know, the whole program is risk-based. And what that means is our whole objective in being in somebody's life is to address the risks that, you know, the things that place them at risk of institutionalization. And so, you know, it turns out that 40 years ago, that vision of helping people to stay out of nursing homes is very well aligned with the current, what people recognize as wanting to reduce readmissions, wanting to keep people out of emergency rooms unnecessarily. It's all linked, you know? And so when you start with addressing those risks that could land somebody in the emergency department, you end up also addressing those risks that place somebody at risk of being long-term institutionalized. And so we do a lot of, you know, health-related care plan problem goals and interventions, you know, falls, caregiver-related, other environmental concerns, you know, cognitive related risks and things like that. And we'll give you some examples of those, what care plan problems and interventions look like a little bit later on in this presentation. And so after we establish that care plan, and I should mention that care plan is not only our view of what's going on, but it's also signed off by the participant or their designated representative. And so it's their, they're in agreement with us in terms of what we're going to be working on. We think of, when Denise talks about long-term care management, we think of a care plan as a 12-month plan, and it is being updated, often as needs change, but that is our roadmap for the year ahead, basically. And then, so, taking that roadmap after we've established it and everybody's agreed to what we're going to work on, month by month, we make contact with that individual, and at least monthly, face-to-face, at least quarterly, but in the intervening months, it could be by phone or might be face-to-face as well. And we are, monitoring that care plan and addressing the problems and ensuring that the interventions are being implemented. And then we're also, I don't think you can really see this very well on the screen. I apologize for that. But we are connecting with other health and social service professionals as well who are involved in that person's life, as well as family, designated representatives, caregiver and such. And then on at least an annual basis, we are reassessing using a standardized assessment tool as well. And then at the point that MSSP is no longer appropriate for this person, whether it's because they're out of home for an extended period of time and we can't continue to serve them in the home because they're not there, or whether they pass away or get better. It happens every so often that somebody actually improves in condition and we can no longer certify them. So whatever that reason, then we move to terminate services. And we really work to ensure that they're in agreement with our plan and understand why we're doing what we're doing. These are Medi-Cal services, and so people have rights. They have the right to grieve that action of termination. I think my colleagues would agree, we don't see that very often because, the key is really that ongoing communication about what we're doing for them, why we're in their life, and why, why that termination might happen. And so that's kind of the care coordination process. And I think we can take it to the next slide. And so this is just sort of another way of looking at the care coordination process. I won't spend a ton of time on this. Is there any way to scroll down a tiny bit?
We are actually in a PDF, which is what I have.
Okay.
And so if we would like to switch out to a slide, I would need to turn it over to one of you to run.
Or can we just hit the minus? But the minus to make it just a little bit smaller. Usually I'm trying to make images bigger, but in this case, it might help to make it a little bit ssmaller. Okay.
There, that's perfect.
I hope.
Okay, thank you for the tip.
Yeah. Okay, so this is just kind of gives you a sense of, the sort of the 360 view of the process, and you're kind of going around clockwise from referral to enrollment. We have all kinds of, for better or for worse, forms that are completed at enrollment, consent forms, and, our ability to contact other people in this person's life. And our nurse, as Denise mentioned, has to certify that the individual meets the nursing home level of care. And that's done on at least an annual basis. And anytime there's a change of condition. And then those assessments, the care plan monitoring, implementation, all the way through reassessment. So that's the 360 view of the process. And then Denise is, I think, we're gonna go to the next slide, and she's gonna focus, we're gonna focus a little bit more on the care plan itself.
Thanks, Eileen. So once the assessment is complete, and part of that assessment process is, or as Eileen described, that assessment process is very comprehensive, but a real key part of that is also that coordination with others that are in that person's life, whether it's the doctor, whether it's other case managers, whether it's other organizations, is to be able to bring together a care plan that doesn't duplicate any of the services that they're receiving, but instead kind of pulls it together, if you will, and is collaborative in terms of MSSP really stepping in where there are gaps in that person's care. And so for the work that many of you do, where, for instance, if a newly housed older adult is in your building, and where you're not able to possibly focus on things like their health management or those types of things, we will partner, and that's the care planning process. So when we develop our care plan, we've taken everything into account to bring to that process. So from enrollment to activation, to then setting the care plan and who's doing what, and how we're working together, as well as what we're doing for the client. And we monitor and do that coordination. And then, as Eileen said, there are intervals for reassessment. So reassessments annually or at change of condition, and or if there's a need to add new items to the care plan. The care plan is a living document for all of our teams. And so we really kind of move through that same continuum, building a plan to help support that individual in the community. Go ahead, next slide. So we thought it was important to show a quick profile of what a typical MSSP client looks like. This is actually from my MSSP site in terms of a composite we have put together and looking across our cases. And so, this is Maria, and Maria is an older adult who, without the support of MSSP, would likely be in a nursing home against her wishes. The goal is always to stay at home or stay where they want to be to age. The real keys here that you'll see as you look down this grid is there's a lot of different statistics here, but one of the things I'll draw you into is the ADL activities of daily living, like bathing, dressing, and grooming, and the instrumental activities of daily living, like housekeeping, preparing meals, those type of activities. And that's a really key indicator of one of many, but part of the frailty factor piece. And so MSSP really looks at those ADLs and those IADL scores, and we have a grid that we do to score their acuity basically to this. And it really gives us a picture in terms of the level of needs, and mirroring this with diagnoses and medication regimens and other socioeconomic factors kind of builds that picture together. So as you see, she's got 4.1 deficits on being able to manage her own activities of daily living, again, bathing, dressing, grooming type activities, out of a 6. So she has a high frailty there. And to manage the other types of tasks like housekeeping, meal preparation, managing her mail, those types of things, she's a 9.2 out of 11. And so we would consider, so this is kind of the typical client. We see that there's a lot of needs there, and this is a key part of our care plan, is to figuring out how we help this person meet those needs. And so so then we also look, as Eileen said, we also look at cognition. So you can see that our average client has some level mild cognitive disorder in terms of after using a validated tool in order to measure that. So we know that we have to build our care plan taking that into account, that they continue to be safe. And then, as we also see with many of our clients, is more than 50% of them live alone and have a real lack of social support and assistance. So again, we're factoring that in while we build a plan to be able to build for their safety. And for the level of income, most MSSP individuals live on $11,000 a year or less. And so that is a very typical, so we know that they're low income. And we also, because we are a long-term program, once we build this care plan with someone like Maria, we're able to then continue to update it as we've described. But our average length of staying with a case is 5 to 6 years in my site. And so really that long-term sustainability, that partnership with that person, as well as the other people in their care circle, if you will, in order to help them maintain in the community and be as safe and as healthy as possible. And so this is these are the types of things that come out of our assessment and what a profile of our clients look like in terms of how we then build our plan of care off of these types of indicators. And I think next we're going to go ahead and take this a step further into what a care plan looks like.
Okay, thank you, Denise. So this is an example of a care plan problem. Very often we have a client will have probably 3 or 4 different care plan problem statements. They tend to be a little more global or general topics, and under that falls a number of different types of interventions and a particular goal. And so month to month, the intent here is that month to month we are monitoring that problem. We may be updating it, as something changes, updating the goal as something changes, and certainly updating interventions when something is completed or something is, a new intervention is needed. And so that's just kind of the structure of our care plan and how we make use of it. And the care coordinator is addressing, so this example is a pretty typical one for our clients because along with being at a nursing home level of care, very often the individual finds difficulty performing their own, housekeeping and personal care. And so this statement, as you can read, gives a little bit of the why is she at risk? What is the problem here? And she's not able to stand for long periods of time, and she's got weakness and pain and some visual deficits. And so the goal is that she get those needs met, basically, that her daily needs are met. She's not going without. And then in terms of interventions, MSSP has some, our care coordination really draws upon the community resources already available. And one of the things about our participants, in California, we have this wonderful program in home supportive services. And one of the things about our clients is they can sometimes have a really difficult time making all of that work because all the flexibilities and the self-directed aspect of the program can mean, you've got to be able to hire your own caregiver, which may be problematic if you're struggling, cognitively, or you're fatigued, you're not feeling well, and that sort of thing. And so our staff will really focus in on how is that IHSS being utilized. And we want to make sure before we do anything else that we are helping that person to maximize that wonderful program that we have. And so you see some of the interventions are referred interventions in terms of making sure that they've got potential care providers that they can interview to assist them, that they've got some additional supports like referred for Meals on Wheels. And so they can maximize their in-home supportive services by supplementing with something like a meal program where the meals are already prepared. You don't have to have that IHSS caregiver doing those activities for you, and they can be, medically tailored to some extent. And then also you can see transportation, as an intervention there, as a referred intervention. Now, care management means something that our staff are really going to focus in on. And care management in this aspect is monitoring the effectiveness of IHSS hours. And very often what our staff are doing is advocating to IHSS to have this person reassess, because when you have a change of condition, your IHSS is kind of good to go for the year, except if you've got a change of condition, that can really place you at risk and you can't wait 11 months or 10 months to be reevaluated. And so we do a lot of advocacy to have people reevaluated. And then one of the distinguishing features of MSSP over a lot of other care coordination programs is that we have a reserve of funding that is a feature of the waiver. We have to be very careful about how and when we use it. It's certain rules come along with it. These are Medicaid funds, but we have vendors, and we, contracted vendors that we look to help us meet needs that are unable to be met by any other community resource, unable to be met by the client or their family. And so in this example, we are actually able to justify purchasing an additional 16 hours per month from a contracted vendor to ensure that the needs are being met. So that's that one care plan example. And then if you want to move to the next slide. So this is an example of an individual, and this is also another very typical example. Pretty much every client has something about health on their care plan. And this tells you why we've got concerns about the health and what kinds of things place this person at risk and what we'll be monitoring. And then the goal is basically that they will have, their health conditions continue to be monitored. And interventions are things, as you can see here, things like collaborating with the physician. And that's, an important part of that is ensuring that the individual or their representative are, communicating with the physician. And sometimes we'll do some coaching on that if necessary and if that's helpful. And making sure that, sometimes people don't know when to call the doctor. And so we try to really make it clear that if something, if you need a medical appointment, contact your physician. If you need some sort of assistance from us, lean on us for that. Also about, not just medications, but other things, as you may know, require a physician prescription. And so we'll call that out as something that almost like a to-do list for the individual or their family. Hey, when you see the doctor, make sure you get a prescription for this as well. And then our intervention there is monitoring. One of our interventions anyway would be monitoring and making sure that the follow-up is done and that the health conditions are being monitored. So I think that's it for that. And then
I'm going to stop for just a minute. We have a great question from Kathy Hetzer in the chat that I think is timely for this section.
Sure.
She's saying, if I see the need for a care circle to be created when I meet a client, are you able to assist with the setup for IHSS for the client, as well as if there is a need but not already in place? And also, do you assist with a transfer from, say, WellCare back to Medi-Cal to be able to enroll in SCAN? This is a SCAN-related one, I guess. I see this as being overwhelming for the individual client.
So there's a few different things going on there, and I'll look to Denise to help me with that. I see you're unmuted too. Yeah. So, one of the things that you're talking about is, helping an individual to kind of marshal their resources around them, their informal resources around them, and, how do they navigate IHSS? I sort of talked about that and didn't go into full detail about it, but yes, absolutely. When somebody's got, very often an individual doesn't have anybody to look to be their IHSS provider, we will help them getting, names off the IHSS registry. And then setting up appointments. We may sit right next to them as they're interviewing people and, helping them to, it's not our job to do that hiring, but it is our job to support. And if we need to provide that level of support, particularly somebody who lives alone may not really have a lot of informal support at this point. And so we serve as that informal support in a sense to help them, be able to put those things in place. And then things like changing, their health, their health plan or, their payer. I think I'm going to turn that over to Denise, but, all of our staff do that all the time. I mean, this is the open enrollment time. Our clients have a little bit more flexibility about making choice with healthcare payers, but yes, we're very involved in that.
So I think the first clarification on the healthcare coverage piece is you do not need to be a member of SCAN Health Plan or any other health plan to access MSSP. So MSSP is a Medi-Cal benefit, and you can still have as your healthcare provider, your doctor the doctor could be through LA Care, HealthNet, any of those. But as long as the individual has Medi-Cal, the individual can choose that I want to enroll in MSSP services and then go through the process for enrollment. So that I just want to clarify that distinction. And although I am from SCAN, I'm from a division called Independence at Home, which is a community service of SCAN, and our MSSP contract sits there outside of health plan benefits. So just want to clarify, if anybody's thinking just because they heard the word SCAN, you have to be a part of a health plan to get MSSP. Absolutely 100% not. It is the Medi-Cal and the choice of the individual. Now, as Eileen said, if the individual is also not, wants MSSP and agrees, again, voluntary program to sign up, beautiful. We know how to do all of that. But as Eileen said, once they enroll with us, if they are indeed dissatisfied with their healthcare coverage and their doctor and their provider, as she said, we do help people make those types of changes. It is complicated. The Cal AIM initiative that's coming will make probably some things complicated. Coordinated care initiative, when it came, made things complicated for our older adults. It will be we understand that, and we can help somebody in our program make those changes.
It's not our decision, though. I want really clear about that one. That's not our decision, but it is our goal to help support, educate people and help them make informed decisions.
Yes.
Yeah.
We have some additional really great questions. So I'm going to continue to have you answer a few more questions, and then we'll move on. So Heather has some great questions. Can you provide language interpretation services?
Yep.
Yes.
By law, we must.
We're required, yes.
Okay. And then how quickly are you able to connect with supplemental worker while waiting for IHSS? And do they have to have IHSS already approved, or would your supplemental workers start during that process?
Yeah, one thing in that care coordination process, a little pie slice that we didn't depict is that as soon as we enroll an individual, we determine that they qualify, they sign the paperwork, our nurse has done the level of care assessment, they're enrolled and they have rights at that moment. And we are able to implement or develop what we call an emergency care plan. And that emergency care plan allows us to meet more immediate needs. And so it's basically at that point, it's just a matter of, how long does it take to get somebody enrolled? Once they're enrolled, that's basically a visit, during that face-to-face visit. And then we can contact our providers and, set them up with some supplemental care awaiting IHSS. It's not a great long-term plan. I mean, we can't, the funds are limited, and the test to be able to meet to provide that, those purchases is, it's not really an ongoing plan, but it is for immediate needs, certainly. So that is a possibility, yes.
Wonderful. And then a third question is, do your services have the ability to do a major clean out to avoid an eviction?
Been there, done that. Yep. Yep. Yes. As we all probably know, most or all of us are social service professionals. There can be a lot going on there that brought that individual to the place of being at risk of eviction because of, whatever's going on in that home setting. And so, yes, we can do a major clean out, but it would not be uncommon for that home, that setting to look that way again in 6 months. And so it's not a great intervention in and, all by itself.
Okay.
So
That's
yeah.
perfect. And then I have a couple more, so I'm going to just keep going because I think this is a good exchange. So what Celia is asking, what is your relationship with hospitals? Do they refer to you directly? And what are your most common referral partners? And then most importantly, is there a waiting list?
Yeah. So yes to all of that. And yes, and it depends. So we see referrals all over the place, and I'm going to look to Aloyce and Denise to augment with this. We see referrals all over the place. And I think a lot of that has to do with our connections within the community, who knows we're out there and knows to refer to us. So my agency, we are a part of a hospital. We're a part of Huntington Hospital. And so between our own hospital and others in the San Gabriel Valley, we see a lot of referrals from hospitals, from physicians, from, to some extent, IHSS and Adult Protective Services, other social service agencies, health plans, a little bit, not a lot. I would think more than we do. What do you want to add to that list, Denise and Aloyce?
So I would add also the community centers. I mean, so the community level that we get more from providers' offices now. It's not the doctor, it's the physician's assistants that actually are coming through more. And I think the other one that's key for us in our area is the resident service coordinators in the low-income senior housing buildings, especially through the pandemic. Their bandwidth I was already thin to begin with, thinner. You all know this, and needing that extra help for their clients. Aloyce, anything you'd add?
Yes, dialysis centers. We get a lot from dialysis centers, from some meal providing agencies, and home health. We get referrals from home health, and we do get a few from health plans, and Kaiser is a big provider of referrals.
Yeah.
And then I see the wait list question there.
Yes,
So
thank you.
so I'll jump in
One
and then
more referral is, and I can't leave it out, is word of mouth
yeah.
from our
Yeah.
other seniors.
Right.
Yes.
Seniors,
Yeah.
and they spread the word of mouth. Yeah.
Yeah.
Yes. Yeah, I agree with that. So there are wait lists. I can speak to my side, and then I'll let Eileen and Aloyce speak to theirs. Ours is pretty low right now. So it's about a 3 to 4 week wait right now, which is low. There's been other times we have been higher than that. And that 3 to 4 week wait is really because it's the time it takes for the assessment process and the staff being able to schedule that. And so wait lists are low at my site right now. And with the expansion slots coming on board in January, I expect that to stay low. The pandemic changed the game because we were pulled out of the field initially. And really how referrals, even though we talked about all those different referral sources, their game changed too, right? ADHCs were shut down, so they could not have services in person. You had, physicians doing telehealth or via phone calls. And so the referral chain kind of changed. And that piece, as Aloyce, that's a good, that I always forget about the word of mouth, because I don't know how many times my staff might be in a building seeing somebody else, and somebody pokes their head out of their apartment and says, can I talk to you? Which, and so with us not being in the field. And so I know it changed it for my site to make it a little easier to access us at this time. So Eileen and Aloyce, whatever you'd like to add.
Yeah, same. All of that, same.
Same here, all of that.
Okay, great. So it sounds like it's MSSP is more accessible right now, which is good for this group to know. So
Yep.
Thank you. And then the last question, and then I'm going to let you go on. Alana is asking about how you distinguish someone who needs a nursing home level care and is at risk of institutionalization from someone who maybe is a little bit more at risk, but really could benefit from less intensive community-based programs?
So great question. There's no easy formula because you really have to look at the whole person, their support systems. It's really through that the assessment process that we really kind of discover those types of paths. So it's looking, but I think some key things to look for are some risk factors. One of the things I mentioned, and then I'll let Eileen and Aloyce kind of chime in, is, access, the ability to manage their activities of daily living, to be able to physically bathe, dress, groom themselves, and then be able to also manage their environment, the ability to cook, to be able to pick up after themselves, the ability to, manage their mail, those types of things, because there's just so many factors that go into a person, right? And then you've got their living situation to factor in. You've got their social supports. Is it somebody that has anybody else that already does these things for them? And so maybe they're okay and don't need as heavy support. Maybe they don't have good support. Maybe they have no support. And then you're also looking at that management of conditions, the health conditions, those types of things. So there's a whole bunch, and these are just some of the highlights of like why it's so complicated to be able to say, like, to come up with a formula of nursing home risk just needs community support. So you really have to get in there. And so for when referring to MSSP, any risk factors you see or they're struggling with, a lot of times a referral comes in and they're like, they can't take care of themselves. Like, that's what it'll say, right? The referral source will say they can't take care of themselves and they can't take, and they're, and then they might say that they're not eating. And so, those are triggers for their, to be investigated through the assessment process to truly figure out the path. And, we kind of run with that. Okay, let's take a look. Let's have a conversation. Let's start that piece. So let me stop there and see what Eileen and Aloyce want to add.
Yeah, so two things really jump out at me as you're talking, Denise. I agree with all of that. It's not a simple answer. And I also would not want you, those listening to this, to try to struggle with, can I certify this person at nursing home level of care? Because I pay nurses a decent wage to do that. That's kind of like beyond my pay grade in some sense. That's really their, that's their license that is on the line to determine, is this person at nursing home level of care? It's not a straightforward, easy question. It really is case by case. But Denise is right. It really backs up to that, what we call a functional grid, all the different factors of activities of daily living and the independent activities of daily living, or instrumental activities of daily living. And the key word that we use there is safe functional level. So just because somebody can get up on a ladder and reach, and change a light bulb, doesn't mean they're safe doing it.
Right.
Doesn't mean they're not about to head to my emergency room and, off they go, no longer independent. And so, what our nurse is looking at in determining whether they can certify somebody's level of care for nursing home is their safe functional level. Do they need some standby assistance of somebody? Do they need some hands-on assistance? And if somebody is mostly able to do things safely independently, they're probably not going to qualify for MSSP. But if they're mostly needing someone, standing by, or they're mostly needing hands-on assistance or some combination of those, then they're probably going to qualify for MSSP. And so that's just kind of a quick and dirty way of looking at it, but it is a more complex question. Aloyce, anything to add?
Yes, I would just add that, and I agree 100% with Denise and Eileen, is one of the things that I'd like to pay attention to are those gaps in care. So they may have a family may have a very strong formal and informal support system, but there may just be a gap from the time the caregiver leaves to the time the daughter returns home from work, and it's a person with cognitive deficits that wanders, left alone, or so those gaps in their care could increase the risk. So I think with our MSSP, we tend to look at those gaps and how we can help fill those periods of time where there's not enough help in the home. And that will reduce some of the risk for that individual at that time, and probably most likely prolong their stay in the community.
Yeah, excellent point. Okay.
I don't think there's any more questions, Gretchen. I think we got them all.
I think we're ready to roll. Here we go.
Well, we only have one more slide left, so this will be easy. And this is actually a continuation of the previous care plan problem that you saw, where here we have what the care management interventions will be, things like referring and getting somebody hooked up with the CBAS center in their area so that they can have the proper health monitoring and support during the day, looking for increased socialization to help with the depression, those types of things. You kind of see all the different ways the case manager will manage the cases. Eileen was walking us through. And then as she's explained, as a last resort, after we've exhausted all of the other supports out there, education and other programs, we have the ability to do purchasing through our program, through the waiver that authorizes us through CMS, is being able to purchase things like, in this particular instance, transportation, so this person can get to their medical appointments, being able to purchase them the supplies in order to be able to care for their incontinence and manage that, as well as, and in this case, even being able to get them the proper linens that they need at home so that they can be living safely and maintain their environment. So this is just like one example of many ways, but we thought it was really helpful to kind of illustrate how this program works from assessment to care plan to delivery and tries to wrap around the individual. So we're done with our major presenting, and we're open to definitely more questions.
And I just wanted to add, if you could go back one slide, I just wanted to add that this is a little bit less common of an intervention, the purchasing of transportation. And that's because health plans, which almost all of the people that we serve, like 95% of the people that we serve, have a Medi-Cal, providing health plan, if not Medi-Medi. And along with that comes the benefit of some transportation, to medical appointments. And so this would be a pretty uncommon purchase for us because we're required to maximize those other resources available. Now, what might be more common is, like, supplemental implies to me that they're already exhausting all of their health plan, transportation benefit. And so we need to kind of come in and do some additional. And another possibility there that's related to transportation that's more common is an individual may need an escort. And so we can hire somebody to go with them to those appointments so they don't get left or lost or forget to come back home or something like that. And, or, even somebody to go with them to kind of help make sure that all the information comes back home with them. So just wanted to point that out. And that's all with that.
And with that, were any more questions that we can answer?
I wanted to start us off with a question. And actually Heather is asking the same question. How can we sign folks up? So we have on the call, I can see quite a few homeless service providers that are new to the MSSP world. And so let's say you know nothing about MSSP, where would you start to get one of your clients signed up?
Well, so let me just, one thing I don't think we went into was that all of the MSSP providers, so we all have our, our contact information. I think it would be good to send that out to everybody after the call is what I would suggest. All of us, all day long, we have staff who take calls, who, contact people back, who reach us various ways, whether it's through a, information portal or whatever ways that the site has available. And we are helping to not only screen somebody in or out of MSSP services, but then also advise if MSSP is not the solution, then how about this and that? And so, you know, our staff who take those calls and do the screening have are well versed in what else might apply, you know, and it might just be somebody they don't want somebody in their life every month, and you know, in their home and that sort of thing. And so it's a voluntary program. We can't force them. Well, what might work better for them? And so they can also advise about some other possibilities out there. And so I just want to say that it's not like you have to get it completely right and call us and that's a useless phone call. Our staff know a lot about other types of community resources available to the same, you know, people with the same type of profile of need.
So one thing, we work with folks from different SPAs, service planning areas. And so I know we have folks from different areas on our call. And I'm also aware that the California Department of Aging has a website that has MSSP providers on it. And we will definitely be sure to send out your contact information. But just roughly, maybe the three of you could say, what are the service areas that your programs serve generally? So folks on the call, on the session today will know like kind of what areas you're all representing.
Okay, you guys think in terms of spas. So I fortunately have a little in my background history back when Gretchen and I first met, have a little experience with spas. Don't deal with it on a very frequently now, but we are in Spa 3, the San Gabriel Valley primarily. Little bit of Spa 1, East LA areas, but mostly Spa 3. And that would be like all the way to the county line and, you know, down that, you know, like Hacienda Heights and La Puente and all of that. So San Gabriel Valley.
Right. And how about you, Denise and Aloyce, if you share?
So for our site, we're all of Spa 8, a little bit of 6 and 7 and 5, 6 and 7.
So
I'm looking, I pulled up the spa map because I had to refresh myself.
So we have the South Bay, we have Long Beach, we have a little bit of East LA.
Yep.
I think of like the Downey area.
Yeah, we go up to Santa Monica and Spa 5. We cross over in Linwood and Compton with one of Aloyce's sites as well. So there's some crossover. There's some fringe crossover in some places that you can call either site type of thing. And then in Spa 7, we go a little bit into go right into that little part of Spa 7 that comes into Spa 8. The Orange County line is the end because in Orange County, Cal Optima is the provider out there. So.
Great. Okay, and Aloyce, we're getting a question about Antelope Valley, so I want to make sure.
Yes, for Partners in Care, we cover all of the Antelope Valley, Santa Clarita Valley, the San Fernando Valley, West and North San Fernando Valley, and East San Fernando Valley along the mountain range, Sunland, Tahunga, Verdugo, Glendale, Burbank. That's for our North office. We have 2 offices. And for our South office covers primarily downtown LA, South Central LA, a lot of LA, Compton, a little piece of, as Denise was saying, Long Beach and Inglewood. So we cover a large area in LA. We kind of touch a little bit of some of the other MSSP.
I should add, we have a little overlap with Aloyce too, Glendale, Burbank. So
yes.
Yeah. So when these were laid out, it was done by zip codes, not spas. The state laid it out by zip codes. That's why this doesn't align pretty on a map.
And there are 2 other MSSP providers in Los Angeles, which is Human Services Association and Jewish Family Services, I believe.
Yeah, Jewish Family Service LA, yes.
Yes, okay. So So we will make sure that you all have not only these three presenters information, but also that you have the link to the California Department of Aging website where you can find more about MSSP.
So
the-
Wyson Healthy Aging, I see that question. Wyson Healthy Aging is not a provider, you know, good service partner to all of us. We work, you know, I heard that term long ago, co-opetition. We work together very well in terms of, you know, if you call my site and you say, these are the needs, and then it turns out you need it in, you know, the San Fernando Valley, we're going to make sure that you get Aloyce's contact information, her site's contact information. So
you
will help
refer
you.
to each other.
Yes, yes.
Good to know. Okay, great.
We do have some information on our website at Partners for referrals for the MSSP Partners Program. So if they go to Partners in Care Foundation, the website, they could make a referral. Just look under the MSSP program.
Great, good. Okay. So we're at about 2 minutes. Anything else before I close this out? Anything else?
We get all the questions answered?
I think we got them all.
Okay.
Okay. So
I'm so sorry, I just thought of one more question. You guys did mention in the very beginning that primarily it's 65 and older with no share of cost, but there was some kind of caveat because there might be some people with share of cost. Sorry to throw out a last minute question. I just reread my notes.
That is true. And what we do is we run their Medi-Cal strip and we can look at the individual clients. So because if they're 65 and they've got things going on that you're worried about and there's a share of cost, I'd still call an MSSP site and let them screen. And they'll help walk through that instead of trying to figure that out.
Yeah, it's complicated by things like the spousal impoverishment rules, and so we can help people navigate if they qualify for something like that, and so it's not an automatic no.
I just had a
okay.
question for
Go ahead, Dan.
Aloyce, I believe that's how you pronounce it. Like, what's the approximate wait time to get, we call them members, to get one of our members connected to services up here in the Antelope Valley?
It will be, even though our wait list is very low, our program is full. So we get terminations, and as we get terminations, we fill those slots. I would say it's about a 3-week period.
Okay, great. Thank you.
Great. Great questions, everyone. Thank you for just hopping on. That's the best way to do it. Okay, with that, I just want to say special thanks to our presenters today and for all of you for being here. It's been a great conversation. It's so exciting to see older adult providers, housing providers, and homeless service providers all together in the same forum. We really appreciate the wealth of knowledge and the sharing that went on today. We will be sending out the recording as well as a PDF of the PowerPoint and links to some of the websites we've mentioned. So thank you again and have a great day.